Good morning and welcome to our day 2. And Kay Garamani is going to speak in just a few minutes, but we do know that there are some people still kind of making their way in from parking. So we're going to go ahead and start off with a video, another way to celebrate successes, and then we'll hear from our State Medicaid Director, Kay Garamani. So welcome and thank you.
I have been told I'm recovered because I'm almost 18 months. In 2 days, I'll be 18 months clean and sober through the grace of God and also my counselor and my groups and things that I go to. They keep me strong and they keep me moving.
1115 Waiver has allowed us to integrate substance abuse treatment into our adult outpatient clinics. This has been a very helpful addition. I come from the case management background. I've been here with MHMR for now over 13 years, and I was a case manager for the better part of all of those. And one of the most difficult things we had to do was to get people to go off-site to get their substance abuse treatment. With the integration into the adult outpatient clinics, we've been able to help more people get the help they need because they're willing to go to a clinic that they're very familiar with.
We have a substance use disorders program on site that helps patients that have the dual diagnosis, which is a very commonplace in our kind of a setting. The way it helps is patients who have ongoing needs, acute needs, and chronic needs that have been going on for years, together with the mental illness. It helps facilitate quick transition into programs that are on site.
Since January 2014, we have integrated substance use services within 8 behavioral health clinics here in Tarrant County. The program offers assessments, individual and group counseling, in addition to peer support services.
Got a lot of stuff going on in your major depressive, you have an eating disorder, you have alcohol and drug abuse, you don't have a place to live, you're homeless, you have nothing but the clothes that you've gotten from a mission or a church. You start to lose hope. I tried to commit suicide January 13th, 2014, and it's been a really amazing ride since then. And I'll never forget my counselor here asking me, 7 months in, she asked me, well, we still haven't gotten one question out on the table. And she said, are you mad that you didn't succeed? And I just started crying because no one had asked me that. But when she asked me that, I really had to dig deep. I couldn't answer her for a couple of weeks. And then I remember when I did go back in there and she said, so we haven't addressed the question, I'm gonna put it on the table again. And I said, I'm so glad that I didn't succeed in killing myself. I'm so thankful to be alive, and I'm so sorry that I even tried to do that, ever. And that's a lot of what this place has done for me, is make me want to live. And that's pretty much the best thing you could ever give to somebody.
I work from a very person-centered approach and have been since I've been here, looking at from both mental health to their substance, how they're going to recover, what type of treatment plan that I need to use. And using person-centered, basically I adjust according to the client's needs.
As a peer support specialist, I kind of fill in the gaps where our clinician has the clinical expertise, but I have the actual experience of being involved, had an addiction at one time, so I bring to them practical experience about what I know instead of what I've read. And with that, we work arm in arm with the doctors, the psychologists, the housing people. We work as a team. And we all meet to make sure that the clients or the individuals that we are trying to help and address the issues that they have, we try to make sure that we're doing almost a holistic approach to everything that they need.
The integration between the SUDS counselors and all the staff members here is virtually seamless. In other words, there is no break in the process of moving the client through the necessary treatment planning.
It's very convenient to have both of them in one place. I'd like to see more clinics do that. It would be really helpful to people. If it wasn't for peer support giving me rides where I needed to go and kind of pushing me forward, or my case manager, or Mary, my counselor, all the groups that are here, even though in the beginning you don't want to go to them, when you just push yourself to go, it's worth it and you kind of get locked in. You start to want to be a part of something bigger than yourself.
Since that integration, we have seen a reduction in 50% of the individuals reporting substance use issues. We've seen improvement of quality of life in their physical health, their mood, their relationships, and overall satisfaction.
For the most part, we found that we've had more success with this way of doing it, because we all get together and put our brains together and try to come up with a comprehensive way where the individual that we're trying to treat understands, wants it, desires it, and goes out there and implements it into his life, into where he can even inspire others and become a productive member of our society.
I just got my own place, thanks to MHMR. I have teeth in my mouth, thanks to MHMR. I have new friends that are drug and alcohol free and have problems too, and I don't feel like an alien. This is my home. This is where I belong.
Good morning, everybody. I'm Kay Garamani. I'm the Associate Commissioner for Medicaid and CHIP and the Medicaid Director for Texas. I want to thank our staff and the Hospital Association and all those who have been involved in making these wonderful videos. I think that when you see what we just saw, actually a person who's touched by the work that you all are doing, it makes it meaningful in a very personal way. We do plan to have the videos that you've seen on our website, and so those will be up probably in the next couple weeks or so. So you'll be able to view those again if you'd like to do that. I hope everybody had an opportunity to explore Austin a little bit, if you're not from Austin. I look forward to a good day with you all. We have a pretty full agenda again today. Yesterday, we had a number of speakers who I think were inspiring and really laid the landscape for what's happening in Texas. The many, many projects that you and your colleagues are doing across Texas. We got to hear from some leaders in other states and what transformation looks like for them, New York, California, Arizona. We also heard from Mark McClellan, who is with the Brookings Institute and was the head of CMS, was the head of the Food and Drug Administration, and obviously is very well versed in what we're doing here in Texas and what's happening nationally. We also heard about healthcare, what's happening in this country with healthcare, how we are seeing costs that continue to rise. We spend more than any other country in terms of our GDP, and yet our healthcare outcomes, as we all know, if you've seen the statistics about how we rank with other countries, are pretty sobering and not very encouraging. The thing that we have going on in Texas, though, with the 1115 waiver, and particularly with DSRIP and all the initiatives here, is the opportunity of a lifetime. I don't think that most of us will ever see a time when we are not bound by the confines of insurance models, billing codes, and things that really have inhibited the opportunities to really make change. And so we're part of a big experiment here in Texas learning ways that we really can transform the complicated healthcare system that we all experience. You know, one of the things that was talked about was the increasing healthcare costs, and I do want to say in the Medicaid program, we've done a lot to try to kind of curb costs, and we have curbed costs. They're in the obvious ways, cutting rates, cutting back, and things that are not really, they're not the things that we can do in the future, because we've done all of those things. And that's why DSRIP and what's going on here is so important, because a lot of what y'all are doing is you are at the place where both good clinical care and efficient care are meeting. You're keeping people out of the hospitals, you're getting them out of the hospital, and you're keeping them out of the hospital with good care, providing things that seem simple, in terms of, let's use, peer supports like we just heard about in the video. Let's use community health workers. Let's really work with the person to make sure that when they leave the hospital, they understand what prescription drugs they're supposed to be taking and why they're taking them, and then check in on them once they get into their home to make sure that they're following through. It's basic, simple ways that are meaningful, both from a clinical perspective, but also from that cost curve perspective that we always hear about. I think what's also most important about DSRIP is that it has stimulated change at the grassroots level, which is where change has to happen. It is where the provider and the patient meet. It is not an insurance company or a managed care company or the state saying that this is what reform looks like and this is what good care looks like. Even if we had all the money that has gone into DSRIP, if we had loaded that into our traditional Medicaid program, if we'd loaded that into our managed care companies, we would not see the kind of change that we are experiencing, because it's a top-down approach, and I think you all know that we have to have a bottom-up approach to really see change, and that's why DSRIP is so important. You all did needs assessments. You figured out what was missing in your community in terms of people who were going without. Where was there a lack of access? Where were there populations of individuals who needed care that they weren't getting? And then you designed programs to fit those needs. You all probably, are thinking, what is all this conversation about transformation? You're a provider, you've identified a need, and you've designed the strategies and implemented them to provide better care. And at a, fundamental human level, that is what is most important. It's a person to person. You are touching the lives of those people who are in your community, and it is the cornerstone of compassion and commitment and the responsibility that you feel for your communities. But it's also transformational at a more systemic level. You are doing the things that have not been provided in the past, or maybe not to the level that they should be provided in your communities, and you're making a big difference. You are diverting individuals from your emergency rooms through some of the strategies that I just mentioned. You're helping people who are the most needy and most vulnerable. We heard from a speaker yesterday. She was talking about the homeless clinic that they've set up in Fort Worth through JPS. And she described how, their initial ways of providing services didn't work. They didn't know what worked because they'd never had an opportunity to cater services to this population and experiment with how do you best provide services to people who are homeless. What they realized is even if the clinic is across the street, you got to go into that homeless shelter. You've got to have your case managers and your peer supports go in and touch the people who need the help, because they don't know how to necessarily use the clinic. They don't know, they don't live the kind of lifestyle where they can set up an appointment and go back a week later. So that's why I think DSRIP is so important. We're testing out the things we've never had to test out. And we are discovering the ways that, the things that we're going to have to incorporate into the future to change healthcare for the long term. We have two big challenges with DSRIP. We have great opportunity. We do have challenges. And I think the two big challenges are, one, that you all have a lot of pressure to meet metrics, to show that you're making progress. We heard yesterday from Clay Johnston, who said, if what you're doing isn't working, don't keep doing it. Really, metrics are a good way to show that you're making progress, and they don't have to be really complicated metrics, but you got to be able to show that you're making a difference, and you've got to have kind of continuous improvement. The second thing is, we are all collectively going to have to figure out, how do we sustain what's going on after the 1115 waiver expires? We are hopeful that CMS will continue with DSRIP at least for a few more years. I think the fact that Tim Hill, the deputy CMS director, is here is probably a good indication that they recognize the financial commitment that they've made to DSRIP, and that they will commit to at least a few more years. Now, what Tim and Vicki, his boss, have told us is DSRIP is not something that they plan to fund indefinitely. So we've got to figure out, how do we come up with strategies, whether that be through Medicaid dollars. Right now, the administration of our program is primarily through managed care companies. We need to be working with the managed care companies. We have 19 of them in contract in the state. We have to be working with them to show them the success of what you're doing. You all are saving them money now. The services you provide for Medicaid consumers is helping the people that we pay them to serve. So we have to help you make a good case that what you're doing is also helping them and saving money. And then the more, more challenging case that we have to make is for the indigent population. Short of a Medicaid expansion or something that looks like a Medicaid expansion, we've got to figure out how to sustain what you're doing, because you're providing services that in a lot of communities have never been provided to people who do not have insurance. So whether that is making a case to the public hospital in your community that what you're doing is important, whether that is talking to law enforcement to show them the results of the behavioral health, mental health, substance abuse interventions that you've implemented, that they are important and they are a good investment for your community. So we'll be working on all of that over the next year, and plus, probably may take us longer than a year to negotiate our waiver, because it is complicated. So we'll be working on those scenarios over the upcoming months and hopefully years. I do want to leave you with one last thought, and it's something that Dr. David Lakey had talked about yesterday afternoon at lunch, when he showed us that the pyramid of the influences on healthcare. I've seen that triangle with a couple of different versions, but essentially they all boil down to, at the bottom, the biggest determinant of a person's health are what we call social determinants, and we hear a lot about that these days. It's how much education have you had? What is your income? Do you come from a protective environment, or do you come from an abusive environment? Those things are most critical. And I know they can seem overwhelming as healthcare providers. You provide healthcare. So to really address those more complex but most essential fundamental needs, it requires partnerships with a broader base of people than just healthcare providers. So forming those partnerships is really critical. Then up the next rung of the ladder are behavioral interventions, and really the way that we live our lives. Are we eating well? Do we exercise? Do we sleep enough? Do we have stress release? Those are, again, very basic things, but they are a very big determinant of how healthy we are. Genetics, also a big determinant. And as you go up towards the top of the pyramid or the triangle, it's clinical care. Clinical care is where we spend our money, but it is not the most important thing of how healthy we are and how healthy our communities are. So that forging of partnerships with local health departments in your community, with public health strategies has got to be a part of the long-term overall health improvement that we hope and intend to see in this state. All right, you all have a very good day. Thank you so much for coming into Austin to be with us and for inspiring us with all of the great work that you're doing. All right.
Thank you so much, Kay. And I do have to say, and Lisa, feel free to join me, just how much we have appreciated the support of Kay as we have embarked on this work. Because, as y'all well know, we're in a pretty big bureaucracy, and. And it takes, and I'll say this about our commissioner too, Chris Traylor, and Charles Smith is already met with us and getting right there with us because, somebody said a long time ago, Medicaid isn't rocket science, it's harder than rocket science. And then, but even beyond that, you think you understand Medicaid, and DSRIP is completely different, and we're serving Medicaid and the low-income uninsured. So, I keep the faith, and Lisa and I are gonna go ahead and do a couple thank yous just because we know it's a Friday. So, I don't want to forget anything. So, we wanted to thank you, Tim. We wanted to thank our great staff. That you guys, I can't say enough about our tables over there. The associations that help us also with the work and working with their stakeholder communities. It certainly, takes the village. What am I leaving out? Anything?
No, I mean, obviously, and this event and everything we do, we are a facilitator, our anchors, and also all of you.
Yes.
I mean, you are the ones that are doing the work. So we're trying to help you do that work, but what has made this event, I think, successful, and we hope continuing today, and really what makes all of DSRIP successful is what you all are doing, hopefully with good support from us. And also, we have literally the best staff that we could ask for. So when people come up to me and say, thanks for putting on a great event, or thanks for, 99% of what you see, it is not because of me, it is because of the folks that are doing the work. And so we really do value them. And Kay, people sometimes ask me, why have you stuck it out at HHSC for so long? Or, it is a tough job, what we do. It is because of people like Kay and their dedication to what we do, and really a lot of the bright people, committed people that we work with, that makes us want to continue to do this work. So, so we are very grateful for your leadership, Kay. Thank you.
And she's been here all day, both days, with many roles, and just said, just tell me what you want me to do and I'll do it. So, I was remiss, of course, in not thanking the anchors, and I do have to give a shout out to Craig, wherever you are, that Lisa and I did not plan our outfits today. So, you and Dr. Raymer, have a counterbalance. Without further ado, we know that there's been a lot of anxiousness about the work that's being done and about what next steps we're going to take. And so we are going to go into the initial proposal at the protocol level for the renewal, so that we can be planning over this next year, over the next steps, as well as if we end up having a gap while negotiations are occurring. And I do want to say, too, that we've set up this event, Kay went over all the great things from yesterday, but we've really set up today to be thinking to the future and giving y'all information that we think is going to be important to be thinking about so that we can take, everybody talks about the 1,450 projects. How do you make sense of what's working well, what's not working well? And it's a hard task for all of us, and we all do it together. So we've set up, this day to be toward that end. So Lisa and I are going to give our, an initial, like we usually do, you guys are used to it. And then we also have a period of time at the end of the day from 4 to 4:30, for you to be thinking about your questions. And that's basically going to be a Q&A session with us, with whoever's still here. And so the Clinical Champions session right after this session is working with our quality stakeholders to be going through all of these projects and helping to identify the most replicable and promising initiatives so that we can start disseminating these and continue the peer-to-peer learning. And so it doesn't mean, though, that we're not going to catch everything, but we're working on organizing that effort. So Jennifer Woodard, who leads that team, is going to have a panel to go through. The work of the Clinical Champions is helping us to inform what we're really narrowing down the menu for replacement projects, and it's being passed out as we speak. Please read the sub-bullets. This, what we're calling the skinnier menu, is for those projects that may not continue and would be replaced. It does not mean your existing expanding primary care project that's going well has to be replaced. So please read that document carefully to not misunderstand it. We're going to change the title before we post it on the website, so it's very clear. I often don't read sub-bullets. We're going to have breakouts. We're going to have a lunch speaker, Dr. Betsy Shankman, who's going to talk about statewide analysis, talk about potential measures we're going to looking at the regional level and statewide level to get your feedback. And we have the breakout sessions this afternoon to continue to improve program evaluation, help to identify, we know Category 3 measures are an issue. So how do we help CMS, how do we work together with them to identify the best way to measure the success of projects? We have strategies for HIE, the ADT, and admit discharge transfer that have as a potential requirement for DSRIP to further health information exchange. So this is all for feedback. We have the panel. This is a working session together with Kay on sustainability in managed care with our managed care representative and DSRIP providers. This is complicated work we're doing. We have work that started, we need to continue it, but we're getting into the details. So that's what today is designed for. So with that, I'll finally get started. Okay. Where's my clicker? There it is. Okay. I'm not going to go through this. You guys know the 3 components. I think you know the goals of the waiver. Okay, I think you know the extension request. At a high level, we are proposing to extend the waiver for another 5 years, statewide managed care, the UC pool, and DSRIP, and that we are making progress. So, and this is all on the website, by the way, and we will be planning to submit, as you know, to the governor's office next week, and then to CMS by October 1st, the extension request. To continue, the DY5 funding level will be our ask, which is $3.1 billion annually. We're getting now to the protocol level. These are the rules of the road. You're aware of the program funding and mechanics protocol and the RHP planning protocol, which is the DSRIP menu. So that's what we're going to be working on now. We do anticipate this negotiation period with CMS, and we, again, like I said, we will be working on transition planning in case it takes longer than October 1 of 2017 to get there. So very briefly, we have received a lot of comments on the extension request. Here's some of the high-level feedback we've gotten. I want to get right to the details. So this is all going to be on the website, and you guys can, get the details. So here's where I'm going to really get started. Okay. So we've come up with really extension principles that we're basing next steps off of to strengthen healthcare systems. And Dr. Raymer and Craig Kovacevic and that panel, even for the low-income and uninsured, gave a very good backdrop to really that goal. We know that program flexibility is important with we know the variances in our state. At the same time, we are looking to try to standardize and make some administrative simplifications, even in this very complicated thing, so don't get your hopes up too much. But just some way for us to be able to manage this more effectively. We spend so much time dealing in the volume and the reporting, and you guys know that. So do expect some standardization. Again, like we've already said, further integrate with Medicaid managed care, value-based payment efforts. We, again, are looking to identify the best practices so we can sustain and replicate to really, of course, the primary goal is to support the healthcare safety net. And those of you that were here last year will remember that Cindy Mann was here, and and Kay said some of this already too. DSRIP is a substantial federal investment. We think we are actually the best state at really the level of metrics that you provide, the review we provide, that there's an accountability, that there's real work going on. You are truly earning these funds. We want to continue to strengthen systems and the coordination that has gotten started. And we want outcomes and just trying to find, again, the best outcomes with, again, sustainability being the goal. Oh, I went too far. Okay. So, we heard from a couple of states doing DSRIP yesterday, and New York, of course, is what everybody talks about, and we do want to learn from New York. I have to say, after hearing Greg Allen speak yesterday, and of course, he was a bit entertaining, and I've had Lyle Lovett's song running through my head, "You're not from Texas, Texas wants you anyway." I have to try to make a joke here and there. Anyway, so while each state's DSRIP is different, we do have to consider CMS in this too, that they are trying to find some way to have an accountability at their level as well. So we do see things going more narrowly defined and more prescriptive, have larger proportions of total DSRIP funding dedicated towards reporting, more closely aligning pay for performance metrics with their projects, and I know this is, not what people want to hear, but more standardized formulas for project valuation and total per provider funding allocation. So this is just what we're seeing and what we have to be prepared for. More recently approved programs have all or nothing payment instead of partial payment, high performance funds, pools instead of carry forward, require participating providers to submit project budgets, may require providers to report at a high level how incentive payments are spent, use attribution models to align a large portion of the state's low-income patients to specific participating providers, and emphasize the importance of sustainability after quality improvements are achieved. So with the extension request, we know this took us years to implement, and we've had many program changes. We know we're still looking to get our outcomes. And we know the outcomes are not always the best match with the projects. We have an interim waiver evaluation that does support our greatest strength in this program that has been so oft already demonstrated here, and the strength of your collaboration. And that is really our foundational place to build from in a very organized way. So your collaboration and your learning collaboratives, this was a CMS requirement that built in, even doing this event, may not have happened if it weren't for CMS putting it in at the last minute in the protocols. And it's really turned out to be such a valuable event. So we do want to continue the existing district program administrative structure. We love our anchors. We love you guys working together so well. We do want to support the majority of the active district projects to go forward, but we do have some that will not be eligible to continue because we do need to sort through what's working best. And if it doesn't continue, it doesn't mean it wasn't the worthwhile try. So we want to strengthen the district and the Medicaid program. We're working hard to incorporate it with our quality strategy, and we have folks here attending the event to help us do that. Use our lessons learned. We want to strengthen with a regional performance bonus pool. We feel like that's pretty much going to be something we're going to need to do. We also have some other program improvements, like I stated earlier, to collect Medicaid IDs, require participation in emergency department, admit, discharge, and transfer data exchange to have a foundational way to do data exchange. So the details of the district program will be outlined in the revised protocols. This is initial information we're providing today. Your first handout that you have on your tables is what we're looking for changes for those projects that would be replacement projects. So if your existing project is going well and it's on the 3-year menu, you're likely going to be able to continue. And you guys should be aware that we did send out a list of projects that may not be eligible to continue last month, and that we will be working through that at HHSC. So by January, to notify projects from that list that should plan to do a replacement project based on the menu that we settle on. And this is all, of course, subject to CMS approval. So we're going to continue stakeholder feedback most likely next week, as soon as possible. We will get a way on our website for you to respond to this document that we have handed out today to get your input. And then we will be continuing to set up other structures for input on the myriad of details that we have that we will be working on together. Oh, I keep doing that. Sorry. Okay. So the initial information you're going to get today is going to be a proposal for metrics for continuing Category 1 and 2 projects, this extension menu you're seeing now, and we'll also talk about metrics for Category 1 and 2 replacement projects. We know we have some projects that we can combine, especially with community mental health centers that are cross-regional, that are doing the same project but cross multiple regions, and some other projects too that could combine for administrative ease. Uses for funds not allocated to active projects, and we know this one is a big issue, and Lisa's gonna, I'm gonna turn it over to Lisa to talk about that one. A regional shared bonus pools, and then we do have a statewide analysis plan that, like I said, Dr. Schenkman is gonna provide the starting point for that today. With Medicaid data, we know we still need to work on all payer data to help us with low-income uninsured on that, and that is a next step. So for continuing Category 1 and 2 projects, all projects from areas included on the 3-year menu may be eligible to continue pending the HHSC review of higher risk projects. Of those projects, though, we are still working on the details of this. Some projects may be required to take a next step, and we also may propose further standardization, and these might be related to QPI and project intensity. So the goal is to further transformation and extension, including by serving additional Medicaid and low-income uninsured individuals where feasible. And an example of a next step might be, for example, if you've been able to establish a new primary care clinic, well, a next step may be to make it into a medical home. So we will balance this goal with allowing projects that are on track to further progress and to account for projects that initially set overly aggressive goals. there is such wide variance right now, and we do understand that some people had very lofty goals and have had a hard time setting that. So we'll be looking at trying to equalize things a bit as we take those next steps. We are working on fewer metrics to report, more standardized metrics. QPI, or quantifiable patient impact milestones, will be required each year, and this includes for both replacement projects and continuing projects. If you have a project that's not on the list, but you think it's a project that should be replaced, you will be able to replace it pending CMS approval, but it's not going to be easier than what is going to happen for those that are continuing, because we want to hit the ground running and make the best use of the investment. And that's why we're trying to work to narrow the menu based on what we've learned so far in DSRIP that are the most transformative, and also set up ways for hopefully you guys to be able to learn from a project in another area that's already done all the processy kind of stuff and can share with you to be able to more hit the ground running. So our initial proposal will be 50% evaluation for QPI milestones and request partial achievement of QPI metrics or perhaps with a reduced carry forward window is a question that we will be getting stakeholder feedback. For the other 50% evaluation each year, we're considering 2 metrics reported via templates, and this makes this also easier for us and you to have data to analyze. So reporting on core components of projects, which includes CQI, and then sustainability planning, including project level evaluation, health information exchange, and integration with Medicaid managed care where appropriate. So with that, I'm going to turn it over to Lisa to take the next steps to walk this through.
Good morning again. And, you know, just to set a little bit more of the framework that our DOS just talked about, we know, we've heard from you that you're very nervous because your projects end on September 30th of 2016, and you've spent a lot of resources and dedication, and you're serving a lot of people. And so there's a real nervousness that as we work through the next year in negotiations with CMS, that you don't know what's going to happen to your project and your patients a little bit over a year from now. So we're really mindful of that. We do ask you to, as our DOS said, to be patient and keep the faith. We know it's going to take a good amount of time for us to work through the negotiation of this big waiver with CMS. So as our DOS mentioned, we do plan to, if needed, propose some kind of a transition period for district projects if it takes us and CMS longer to figure out what the next step is, so that, you know, you don't suddenly have to stop serving the patients you're serving or have a giant change in what you're doing. And I would also just echo what our DOS said. These are all initial HHSC thoughts about how we can improve the program and streamline it in the extension period. All of this is subject to CMS approval. And we do know from New York and other states that there's certain things that they're probably going to ask of us in addition. So this is our initial proposal, and as soon as we know more from CMS about what they might want changed, we're going to, as we always are, be as transparent with you guys as we can about where we think we may need to be headed. And we knew when we developed the extension request that that was a pretty high-level ask, and that the real work on DSRIP, because where the rubber hits the road is all of these details, was going to come with you this fall as we work to submit the protocols to CMS early next year. So I would just say that we know that we and you have a lot of work ahead of us on this piece. And with that, one of my favorite topics, quantifiable patient impact. Sometimes our staff shakes our heads about this. And we did talk yesterday about how this is still an output measure, you know, of how many people you're serving due to your project. We do think, though, it is a good piece of information that we already have built in to show that these projects are able to provide a lot of good services, particularly to Medicaid and low-income uninsured. So this is one of the metrics that we do want to keep for the extension period, even as we work to streamline, as a key indicator for project impact. And HHSC has used this also to look at project valuation. So one of the things we've looked to see kind of if projects seem roughly within a range is how many additional people are you serving who are in our target populations. We are considering, we have some metrics currently that are encounters for quantifiable patient impact and some that are individuals. We are considering changing all of those to individuals. And that doesn't mean that we would not still be asking, projects are obviously still tracking their encounter level data. For instance, when we look at what's the impact of this waiver across Texas, right now we kind of have, it's a little bit tricky to explain that because of the differences there. So that's one of the things that we will be further working on. And we're going to be having a webinar probably in late September where we flesh this out in even more detail. So be looking for that. You know, good times, exciting webinar on disparate protocols. But we do want your input. So you're going to get some more details on all of this there. And again, depending on that timeline for negotiations with CMS on waiver extension, we would be looking to continue, you know, can we continue our quantifiable patient impact a little bit longer if it takes us time to figure out what the next steps are. Replacement projects, and our staff has handed out the draft menu that we are proposing to use for those projects that need to be replaced. And again, we're looking at a good list of projects now, both that were in certain project areas, but also some that looked higher risk to us to let you know by early next year if we think you need to replace the project. And again, depending on timelines of negotiations, we would be asking that current projects be allowed to continue in a gap period. So for the extension menu, oh, I think I skipped a slide, or maybe I didn't. So who can submit a replacement project? You know, we've already told you that the 4-year projects in certain project areas, 2.4, 5, 2.8, and 1.10, most of those won't be, we are proposing that those not be allowed to continue in the extension period, except for some learning collaborative projects in 1.10. We also have a handful of projects that were withdrawn after June 30th of last year, and so we'd want to give those providers a chance if they wanted to propose a replacement project. We have some high-risk projects based on our review that we're going to be looking at this fall. And as our DOS mentioned, you may also just say, I have a project that's not working or that I think has run its course. I would like to propose to do something different. If you want to do that, you would be working from this newer extension menu. And we are proposing that the valuation constraints be the same as the original project, not to exceed the original limits we had, which was that $5 million per demonstration year. Having a little lag in my... I've shut it off. Okay. So if you look at the menu that you have in front of you, and again, this is for your feedback, we do want to further transformation. So it is a streamlined version of our current protocol. We combine some similar project options and we remove certain project options with the goal of keeping the most transformative options on the menu. It's designed to build on the lessons we've learned in the initial 5-year waiver. Our DOS also mentioned this. We're looking for opportunities to hit the ground running. We're now getting good information on a lot of our projects through the clinical champions. So how can we take what we've learned so that these replacement projects don't need the same startup time for development as we initially did by using what we've learned? Project options that are not in this menu, they may often be woven in as a component of a project in the extension. So if it's not a standalone project, that doesn't mean we don't want you to do it anymore, but you might be doing it as a part of a larger project. And again, some project areas and options were consolidated to avoid duplication of options across project areas. So we saw that where we had a number of projects that were kind of doing the same thing, we've collapsed those into one. We did consult the clinical champions in developing this draft menu, and the clinical champions, you're going to hear more about that later today, but it's a group of clinical quality and operations experts from around the state who are helping us to look at at summaries of some district projects to look at where we have some great results. Replacement projects and metrics may be more standardized than the current district menu. So one of the things we're really balancing here, we gave a lot of flexibility in the initial projects, and it has been an administrative nightmare for us and for you, I think. So as you heard yesterday, what is the data we have to show what these projects are doing and the value to Texas? If we don't further standardize, it's going to continue to be very difficult to tell that story. And frankly, we also just can't keep up with the workload. So we are looking for ways to both standardize and also to streamline what you're reporting to us so that hopefully you're doing less busy work, but we're getting the most important information from you rather than getting a bunch of information that maybe we're not even spending a lot of time looking at, but that you guys are taking a lot of time to generate for us. I also want to mention that the menu you have in front of you does have a high-level reasoning if we didn't include a project option on the extension menu. And, we in the clinical champions, and we didn't always agree, on what, of course, we know people want to keep everything on the menu. The menu was giant, the flexibility was extensive, and we need to move on to the next phase. So, but we still do want your feedback if you see something that you think is a real omission or that is a major concern to you about that draft menu. Combining existing projects, and we think this is kind of a quick win for district administratively, particularly, and this just was the way it worked out initially, we're going to ask CMS if our community mental health center projects that are similar, can choose to combine into 1 or 2 home regions. So we had MHMR centers, and you know who you are, that cover 10 counties, and you crossed 4 regions for district, and you had to do 4 telemedicine projects, rather than just doing 1 telemedicine project for your MHMR catchment area. So we are going to propose to CMS, why are we tracking 4 separate projects here? Can we just collapse these down administratively into 1 project? And we'll be working with you on that. We do also have projects from 1 or multiple providers within an RHP that provide similar services to different populations. We're going to recommend that those be combined. So for example, you might have 2 prevention programs, 1 targeted females, the other targeted males, same project, similar project. Why not have those just be 1 project? In combining projects, we're going to be looking not to reduce your patient effort and also not to exceed those valuation limits that we had agreed to with CMS. A lot of questions about this in the extension discussions. We are still proposing that the performing provider continue to report and receive payments. So if you are the performing provider for that district project, we're not proposing any change in how that works. You may have subcontractors or collaborating providers, which is wonderful, and we know that many of you do work with other community partners. They would continue to have that, they would report information to you, you would pay them market value for the services that they're providing to support your project. And our staff is working on timelines, and we have a lot of work ahead of us, but the timeline for requesting combining projects is planned to begin in January of 2016. So this is a very popular topic. A lot of people ask us, is there money for new projects? We have providers that didn't get to do distrip who want to do distrip. And I'll talk about this some more, there are multiple ideas for sort of cross-regional initiatives that are bigger than individual district projects to support what we're doing. For projects that need to be replaced and those that were withdrawn after last June 30th, we're going to give that performing provider the first opportunity to propose a replacement project. Assuming that most of those providers do want to do replacement projects, we actually don't have, and assuming that CMS approves $3.1 billion distrip a year, we don't have a lot of money that's not dedicated to current projects. Right now, it is under $15 million, all funds across the entire state per year. So I just want to put that out there. That doesn't mean that we're not going to look at what to do with whatever leftover funds we have that CMS may allow us to use for other things. But it's not like there's a giant amount of money that is not allocated to existing district activity. And so I just want to make people aware of that. It may grow a little bit, but right now, statewide, we have less than 15 million all funds total. So if you can convey that to the folks that are asking, and again, not that that means we're not going to be, it might not grow a little bit and that we don't want to look for a good use for those funds. So what are some of the uses for leftover funds? We have talked about increasing the minimum valuation of the smallest projects. We've seen a lot of our tiny projects struggle. The program is complex, it's administratively burdensome, so we would like to be able to bring the very smallest projects up to a minimum level to allow them hopefully to continue. We do want to keep the funds in the RHP, and this again is up for stakeholder feedback, and we've gotten some. But if you did lose some projects that aren't going to replace, you know, the consensus or the majority opinion seems to be that we might leave those funds in that RHP to propose additional transformative activities, including maybe to support learning collaborative activities, and maybe to allow some new providers in. If we're going to have these statewide bonus pools, the regions are really going to have to work together collaboratively to achieve those goals. So we may need to ramp up what we're doing in the learning collaborative world to support that. And then I wanted to talk a little bit about these broader transformative initiatives. And in the past months, various stakeholder groups have come to us to propose ideas for broader multi-regional and or multi-provider concepts that would further district successes. And we're open to looking at these, and we are looking at these. So I just wanted to give you a sense of what some of those are that we've heard. One is across the state, could we look at pediatric rapid cycle quality improvement projects at children's hospitals, and then potentially extending what they've learned into other settings, community hospital and non-hospital settings. There's an initiative proposed to support rural hospitals on some of the key issues that they face that are unique to rural hospitals to help them change with the changing healthcare environment. How to do patient-centered medical homes in the rural setting, data-driven care coordination, admit, discharge, transfer, infrastructure support, telemedicine, and data collection and reporting. So an effort to help our rural partners. We have heard proposals at a high level of potential ways to further develop systems of care for the low-income uninsured. And we know some of our providers, especially our larger providers, already do some of that. And then also an initiative to help coordinate care for emergency department superutilizers. So these are things that much of which is already going on in district at an individual project level, but initiatives to further support those efforts more broadly. So one of my big takeaways yesterday, and it's a daunting task for all of us, is what is the data that we have and how can we use it to demonstrate our success? And we have some significant challenges there because we are Medicaid, we have Medicaid data, you all have provider level data. We don't have a lot of data on the healthcare services being provided to the low-income uninsured, who are one of the target populations of the waiver. So I think Texas has some unique challenges in the data arena. But having said that, one of our proposals to CMS are that we do want to have a statewide analysis plan where, using the data that we have available, we can show year over year, are we seeing improvements in key measures in Texas? Both for Medicaid and for maybe some all-payer data that might help to pick up some of that low-income uninsured. So we're going to be, Dr. Betsy Shankman with our External Quality Review Organization is going to be showing you some data today. Some initial data they've run from 2013, RHP level data on some of the Medicaid measures that we look at for the health plans. So kind of taking another cut of that and saying, for asthma control, how are the RHPs looking? And these are the types of things that we'll have to decide with you what exact measures we want to put in that plan, but we want to show you some ideas of things that we already collect that without an additional cost, HHSC could provide year-over-year data on how your RHPs are moving the needle. And I already mentioned the challenge about the low-income uninsured, and one of the things that we are looking at for that is that our sister agency, the Department of State Health Services, does collect hospital all-payer data. They're starting to collect emergency department data. And if we can get that data, we could do some all-payer analysis as well, for example, of potentially preventable ED visits or potentially preventable hospital admissions. So that's something that we're looking to do. Okay, so Category 3 and Category 4. This is something that is new that we're presenting today that we wanted to talk to you about. in terms of how you measure district success, right now, our Category 3 is our pay-for-performance component of district. And that's at the project level where you're reporting outcome measures that are associated with your projects. Our Category 4 is hospital-level pay-for-reporting of PPEs, some patient-centered healthcare, some ED data. We've had some challenges with Cat 3, and so have you, and we know that. So one of the things that we would like to propose to CMS is that we continue with Category 3. We want to keep collecting that data that you're collecting, but switch that to pay for reporting. So that would be a data point that we're getting on your individual projects, getting paid for reporting. And on the flip side, we switch Category 4 to pay for performance based on that regional performance that our DOS talked about. So we know CMS is interested in shared accountability. So if we have regional shared performance pool, that, and I'll talk more about this in detail, that would kind of be the pay for performance component of district. A little bit more for why we think this switch might make sense. You know this better than I do. Category 3 is extremely complex. We have a lot of providers, a lot of measures. There has been a tremendous amount of TA, and people are still struggling. We do think, though, that there's a value in building measurement capacity at the individual provider level, and we do want to know if these projects are making a difference for the patients they're serving. And so we think Category 3 does help us to get at that information. But given all the challenges we've had, and we've seen this in other states too, it might make more sense that the pay-for-performance component of district is based on our data, on state-level data, rather than data that we're relying upon providers to feed to us when providers have different capacities to do that. So what we're proposing is that all district providers would have a portion, would have their Category 3 converted to pay-for-reporting, and then all district providers would have a portion of their current district valuation converted to their potential earnings from your region's performance bonus pool. And initially, we're thinking that would be 5% of your funding for our smallest providers and 10% of funding for other providers. So if you look at how much total valuation you have for your district in DY5, if you're a big provider, 10% of that, we'd be saying it's still yours, same IGT, same valuation, we're peeling it off for this performance bonus pool, and the smaller providers, 5%. For most Category 4 hospitals, we can just probably take your Category 4 funding and flip it to this bonus pool. We have Category 4 providers that have more or less than 10%, so we've got to do that settle out. And then for non-Category 4 participants, and right now, only our hospital providers are in Category 4, so the non-hospital providers plus our smaller hospitals that are exempt from Cat 4, we would be taking that 5 or 10% proportionally from their other valuation. So it's still your money, it's still your valuation, we're just setting it to the side for this performance component of the program. And we know we still have a lot of work to do on this, but as I mentioned, state-generated data versus provider-generated data would be used for those regional shared bonus pools. And you're going to hear from Dr. Shankman, so this is to start that conversation at lunch today. We're going to need to ensure no duplication of federal funds. So, and we think we can do that. For example, we are looking at potentially preventable events in a lot of ways in Medicaid. But we do have some individual programs where hospitals can lose or earn money for performance on PPEs. This is not an individual hospital incentive payment, it's a regional incentive payment. So we'd be working to make that case to allow us to use those important measures as part of the pools. We're thinking that there would be some common measures that the state would say every region needs to have these 3 measures as part of your pool, but that also each region could select from a list of measures a handful of other measures that you think are most appropriate for your region, for that regional pool. So we know our regions are different. We know some of your needs are different and some of your project focuses are different. So it could be that one region is really focusing on diabetes, one region is really focusing on asthma, one region is really focusing on substance use disorder. So that would give you some flexibility to look at where you think your region needs to make improvements and what you're focusing your district activity on, to help shape your region's bonus pool. We need your help with this. So we're just gonna keep saying that. This is really important, we know that, and so we have asked for some stakeholder input on this, and so far folks haven't been super forthcoming. We're thinking now, maybe you'll be more forthcoming with the actual, we wanna move towards this bonus pool. It's important for us to know what measures you think would be workable. And this is just our last slide that we put in with our website and the box. So, so with that, this is a lot of information. And our DOS said we do want to give people a little bit of time to digest this, and we can definitely do some more Q&A this afternoon as well on some of these details. But I don't know how we're looking on time. Do we have a little bit of time? So if anybody has initial questions, and I know you do, we'd be happy to take those now. And the microphones are coming around.
If you have a question, please raise your hand and wait for a mic.
Dennis Scholl from Community Realize. I didn't see much attention to the reform part of DSRIP in terms of things that are coming and going. A lot of folks use money for new projects, but some of, it's sort of like with airplanes. We don't still fly the Wright Flyer. We're flying an F-22. I'm assuming that some of the improvements should be things that replace things that weren't working quite as well, and those things should be stopped, and the reform projects continued, and they used the money that used to be funding the ineffective things to transfer over to the new effective things. An example would be improving the prioritization and case management and skills training for people with severe mental illness, paying more attention to their physical health condition rather than things that might be not taking care of their physical health problems that cause them to die earlier, as an example. Does that make sense to you?
It does, and that's exactly, if we didn't make that clear, that is what we're proposing. So we're proposing that projects that are on track that are doing well will continue. Those can still be strengthened, and we want them to be strengthened. Projects that aren't working well would be replaced with something that is better or that the community has decided is the next step that they want to take.
Lisa. Hey, good morning.
Nicole, good morning.
Thank you for this and the opportunity to comment. There's a ton of questions, of course. I have a question. If you've given any thought about how the issue of combining projects and replacement projects might work together. So if we have similar projects within our region that we combine and we can realize any cost savings or any value savings is a better way to say that, would there be some eligibility to take that remaining value and consider a quote new replacement project for that portion that we saved? So that's kind of one of the questions I have. And then just the other comment I have is around the performance piece. Personally, it'd be great if you could make up an example of how that might look in terms of their 5% versus 10% and a couple of measures and how that impacts. And then with the 5 to 10%, the idea of partial achievement.
Yes.
With that. So
thank you. And to your first question, Nicole, about the combining and replacement, we do want to work with providers to be able to do what you're talking about. Some of those logistics with 1,450 projects, we're still working through, but yes. So you could say what you just said. We have 2 projects. We're going to combine the 2 into one that maybe is only cost 75% of the initial 2 or is valued at that. And then we have this other idea that we think is really important as a replacement project for our community. So we do want to work with you to do that. Our team is still thinking through the mechanics and the logistics of all of that given the volume. And your point about the performance bonus pool example is a good one. So we can work to do something on that. One of the things that I forget sometimes, there's a lot of stuff in my head, and our staff has been talking about some of these ideas, but getting hit with these things cold for the first time, you may have no idea what I just said. So we do want to help to make it more clear. No, I mean, it's complicated. So we will work on ways to help to explain that better.
Hi, Lisa. I have a question. I know you talked a little bit about the reporting, like in New York, things like budgets, et cetera. When will we know a little more about how the valuation will be determined? We spent a lot of time in Waiver 1.0 on back and forth, and I don't think we ever quite understood the formula in the end, so.
Sure. The valuation question, you know, one of the things that we're going to propose to CMS, and this is part of how long it took us to bring this very large 300 provider program up, is that we continue with what we're doing. So we're not proposing a change. You know, CMS and HHSC both reviewed the valuation of the projects and approved the valuation of the projects with a few exceptions where there were some adjustments. So we're not proposing changes to that. I would say, though, that HHSC is taking a look at standardizing some metrics. So as we go to standardized metrics and say, you know, this is a low intensity project or a high intensity project, you're serving a lot of our target population or a few, there could be some cases where we say, if you want to keep your valuation, you need to serve some more of our target population. So we'll give people some options, but we're proposing to CMS that given that it did take us a long time for them and us and their contractor to review this, that we let the program continue for a while.
Mary Dale Peterson from Driscoll Children's. I'm wondering if there's any consideration for like the children's systems. We cover 3 regions. If there's a way of combining our reporting or whatever into one instead of having to report 3 different regions, that would be one question. The other thing is some of our projects, we depend on claims data coming through our system, and the current timelines on the reporting don't allow for the claims lag to run out. Normally, you know, we like to have at least 3 months to account for that. So I'm just wondering, you know, as we look to the future, if those could be taken into consideration, especially if you're going to run more projects through the MCOs, you know, we will have to take into account the claims lags.
So the 2 questions, the first was about combining the children's hospital projects that are in multiple regions. And we have thought about this. Our initial thought was that because, for example, Driscoll, there was a need for projects in South Texas, and you all were willing to do some projects kind of outside of where your main hospital is, right? In those cases, our initial thought was that we think it's still important to report the Driscoll project in Region 5 or in Region 20 versus Region 4, only because you've kind of taken up a portion of that region's allocation to serve that population. So we can discuss that more, though. We don't have, there are only a couple of our children's hospitals that are in that situation, so we can talk to you more about that. Your point about the data lag is a very good one. And so we'll continue to think about that. The way we have it set up now is that you report twice a year. We do have carry forward that can help with that claims lag, but that still is a little bit beyond probably the 90 days. That takes you out another, almost another year before you get paid. So we can definitely consider that as well.
Hey, Lisa, Susan Seidensticker from UTMB. Could I ask you to go back to slide 22, please?
Sure. My clicker doesn't always move as fast as I want it to.
Well, this is about the combining projects within an RHP that provide similar services.
Yes.
Are we talking cross providers?
If you chose to do that, you would need to have one performing provider.
And that's what I was asking about shared risk. If you had something, would there be an instance where you'd have a 50-50 between 2 TPIs?
We are still looking at one performing provider. And one of the things, and this has been a struggle for district in Texas, is how do you encourage collaboration given some of the financing constraints? So, that's something we can continue to discuss with CMS, but with the complexity of all of this and not wanting to further complicate it at this point and wanting to give projects time to play out, we are proposing that it's still that same basic structure. So you'd have to think about that when you're deciding whether you want to combine.
I have a question. I'm Charlie Ben. I'm here with Bluebonnet. We appreciate what you and our DOS have both done in extending the waiver, but we heard a lot about innovation, and this question may really be for Kay. When are you going to more aggressively get the MCOs at the table to change the payer system so that they're paying for the things that you're promoting through DY3. It's not going to sustain without that.
And that is, if you have read the extension request, that is laid out in the extension request, that we do want to work to further, to have a roadmap for how we're going to work with our managed care plans and our district providers to look at how we can do more value-based purchasing through managed care for things in district that are showing results. If you're showing in district that you're keeping a managed care plan's clients from hitting the ED or hitting the hospital, I bet they would be willing to work with you, because you are helping their patients and saving them money. So I think those discussions are starting. We've talked about this. We have had a challenge in what data do we have to show CMS or to show a managed care plan the value of your project. And we need to get there because we know we need to go in this direction. So we've got a lot of our plan representatives here today, over 20. And that is why, and Kay will be facilitating that session this afternoon. This is an area that's very important to HHSC, so we want to keep working with all of you on that.
Shalon Hoover with Spindletop Center. We have a project that was withdrawn, and I have a question about the dollars for that. Can those dollars be added to an existing project rather than having a new project? As an example, we have a mental health deputy project that only covers one county. We'd like to expand it to other counties, but rather than creating a new project for those other counties, could we just add the dollars to that one? And the second question is, when are those dollars available?
Multiple part question. Okay, let me know if I miss any of it. So we would have to take a look at your first question. I think we are not at this point, we don't have funds for increasing valuation of projects. But I mean, that's almost like you're proposing a replacement project in a way that covers more counties than your original project. So we can definitely take a look at that. When the funds will be available, and this is the big question, we have not yet succeeded in getting a waiver extension. So I want to mention that with Mr. Hill in the room. We are making our ask. September 30th is when we will send that extension request to CMS. And we've put a lot of time into it, so we're very dedicated to getting that done with them and with you. This is a very complicated waiver, and there's a lot of issues at play. The uncompensated care pool is a big part of this waiver that has some separate issues than DSRIP. And DSRIP has its own issues with CMS. As Kay said, CMS does not see ongoing DSRIP as true transformation. They want us to take the learnings of DSRIP and move it into our Medicaid benefits, move it into our Medicaid managed care, to find sustainability plans for the good things we're seeing in DSRIP. So we know we have a negotiation ahead of us with CMS, and we're going to make a good case. If we were to get the negotiation completed for October 1st of 2016, then potentially, we would still be on our same cycle. So what we would call DY6 would start October 1st. Potentially your first reporting period would be in March if we stay on our same cycle for payment in July. Now that's assuming that we get all of this negotiated pretty quickly. So I do think there's a high probability that it won't happen that quickly given the complexity of the Texas waiver. So as we've done throughout this whole process, we're always chasing our tail. We're always trying to catch up because of the massiveness of this program and what it takes to get things developed and approved. So that would be best case scenario. And I think our DOS mentioned, I mentioned, we would be working with CMS on some transition time if we need it for all of the good work that's going on now, if it takes us longer to negotiate what those changes are. To allow you to continue the work that you're doing. One thing I wanted to mention, and this is in the slides, we didn't touch on it directly. We will be required to submit to CMS, and we're waiting for that request, and we know it's coming, a report that lays out kind of the financing of these two pools and how that relates to our Medicaid rates and uncompensated care in the state. So that's going to be a piece that they're going to consider for the extension. And I think they're going to ask us to submit that report by April of 2016. With our contracting requirements, we think it may need to be a little bit later, but that's one piece that's going to inform how they respond to the extension request. And that piece of information likely would not even be to them until spring, summer 2016. So there's a lot to consider.
Okay, I have a question. This is regarding the list we have of the summary of the transitional extension protocol. And I was looking over it, and there's a lot of things slated to be removed from the menu with the reason that no providers selected the project option in the past. And there's a couple that they say you can add as an optional core component. And so my question is, might there be the possibility of having more of these to be considered as optional core components under other existing projects? Because I know for us, the reason we didn't choose some of these in the first round is because we had to lay the groundwork first. We weren't ready to move into some of those things. And, you know, for an extension, we would be poised to start including some of these things.
Absolutely. If you have suggestions on things that you would like to see added as components of other projects, please let us know. We're trying to streamline the menu and to kind of keep a narrower list of projects that we think are the most transformative. That doesn't mean that you can't do some of these things as part of a strong project. So, you know, we don't want to inhibit innovation or trying new things. We just know that what we have is we need to bring it in a little bit. We need to be focusing on some things that the state is saying. We really think these 20 things are top priorities versus these 100 things.
Carolyn Belk, Houston Methodist. Many of us are going through a lot of technology changes, changing electronic medical records. October 1st, we go to ICD-10 coding. We're looking at that in terms of our data collection with running parallel systems or manually coding, how that's going to impact our data. What have you been looking at with regard to our reporting requirements as we make that major change over from ICD-9 to ICD-10?
That is a good question. And yes, ICD-10 we know is a looming challenge for all of us. The state has spent a lot of time, and we know that the implementation won't be without its hiccups just because of the complexity of all of this. You know, on the DSRIP side, I think, and we've had this question from a number of providers, you know, for example, for category 3, you may have in your technical specifications that for a certain measure, these are the 6 diagnosis codes you're supposed to include. And we know that depending on how folks have crosswalked those different diagnoses for ICD-10, there could be some variation in what is reported. You know, at this point, what we're asking providers to do, because we don't have time to change all of the Cat 3 technical specifications, we're going to rely on the provider. You know what and also, even without ICD-10, these quality measures are changing frequently, and we know that. So we're going to rely on you to tell us that you have done your due diligence and that the ICD-10, that the diagnoses you're reporting for that measure, to your knowledge, are a good fit for that measure. But we know that's not going to be completely standardized across all the providers, and there's really nothing we can do about that at this point.
Judy Harris from the Houston Health Department. I have 2 questions. One is about what the process is going to be to look at the projects that may not be eligible for extension. And then also the question about, you had a clinical champions work group looking, I think also making recommendations, and from a population perspective, the name itself kind of denotes clinical, and a lot of the things that need to happen are not clinical. So I'm interested in what's the population focus advisory group, or does the clinical champions advisory group also include that?
Sure. So 2 separate questions. The first was about the projects that we've told, we're looking at your project as potentially needing to be replaced. And some of those are ones that are in those project areas that we are not seeing as a great fit for district for the extension. So we're asking those folks if they can transition into something else, hopefully building on what they learned in that project. So not to say that those projects didn't have value. Our team, and it's like everything we do, it takes a lot of work to do a qualitative review of a single project. These are hundreds of projects. So we're going to be looking at all those projects this fall. Some of them were identified by the independent assessor as higher risk, but a lot has happened since then. So we're going to be going back and looking at all the data we have on these projects, at your reporting, if you did submit something to Clinical Champions, to see if these projects look like they're on track, if they've gotten back on track, or if it's something that they tried. You know, we've seen people say, I just can't get a dentist out here. You know, my project was to increase dental access in a small county in West Texas, and you know what? We've done everything we can. We cannot get a dentist. That project should not keep going. They should do something else, because we don't think they're going to get a dentist, so they're not going to be able to, you know, to achieve the goals of that project. So we are planning by early 2016, January of 2016, to let you know if you're on that list, if we think your project needs to be replaced. So we've asked people not to panic yet. And again, you see the menu here. So I think if you're on that list, it's good to start looking at this menu as at least as a draft to say, what would I like to do if I need to replace my project? Which of these would be a good fit for my community and able for me to do as a provider? So I would advise you to start looking at the list, but we don't want people to panic because they're on that list. We think a lot of the projects on that list will be allowed to continue. We just need to have a chance to look at them. Your question about population health, the Clinical Champions group is pretty broad. It is called Clinical Champions, but we have quality experts, we have association experts broadly, and operational experts from the anchor community. So we have a lot of folks that are helping us with that. And the other thing I want to emphasize about that is that there are questions on the transformational impact summaries around population health impacts. So that's one of the things we want to look at. Those are being used to help identify best practices. Those aren't being used to cut projects out of district. So I don't want you to think that we're using the Clinical Champions in any way to make a decision about whether your project continues. They're really an input for us on what are some best practices and how do we move the program forward. But certainly if there's an interest in additional representation on that committee, we're open to that too. We know people are busy, so sometimes it's hard to give up the time, but if there's somebody we've missed and we can let folks know who's on that group, we're open to broader representation.
I'm James Williams from Lakes Regional. In our communities, we had a lack of primary care sites. And so 2 of the hospitals created and expanded their primary sites, and we created a mobile primary clinic to carry to behavioral sites. And so our goal for the future was to stop the mobile primary site and to go into a partnership and expand their primary sites that they established with the current project. And so as I look at this, it says that, you know, you're going to remove off of the list the expansion of existing primary sites. So I would really like to transform our mobile clinic into an expansion to partner with hospital expansion of their sites. And would that still be possible?
So it sounds like what you're trying to do is integrate behavioral health care and primary care, right? Further integrate behavioral health care and primary care? Right. Sure. So the integration of behavioral and primary care is definitely continuing. So it sounds like there will be a way, if you wanted to combine the efforts of those 2 initiatives, to do that. And we can work with you on that. What we're not wanting to do in DY6 is get a proposal that says, I want to build a new primary care clinic. And not that they're not important, because they are. We've built a lot of primary care clinics, and they take years to get up and running. And so now that we have a lot of them up and running, we want to expand that capacity, but we also want to be encouraging the innovation that goes along with that increased primary care access. So I think there's a way to do what you want to do within the framework we have, and we can work with you on that. Are we up? All right, we're going to let you take a much-needed break, and we'll be back for more on the clinical champions afterwards, 15 minutes.